To auscultate the anterior chest, take the same systematic approach you used for percussing the anterior thorax. If necessary, gently displace the patient's breasts to auscultate all important areas. Now let's listen as the examiner auscultates. To auscultate the posterior thorax, begin at the apices and proceed downward, moving systematically from side to side. Now let's listen as the examiner auscultates. If you hear bronchial or bronchobasicular breath sounds where they should not be, listen for transmitted voice sounds.
Now I want to say
If you want to check the level of the right diaphragm anteriorly, percuss from resonant lung downward to liver dullness. Are intermittent, non-musical, and brief, like dots in time. Fine crackles are soft, high-pitched, and very brief. Coarse crackles are louder, lower-pitched, and longer. Compared to crackles, wheezes and rhonchi last much longer and sound more musical. Wheezes are relatively high-pitched and have a hissing or shrill quality. Rhonchi have a lower-pitched, snoring quality. To examine the anterior thorax, have the patient lie supine and breathe normally. Observe the condition of the skin and inspect the chest for deformities, asymmetry, and respiratory movement. Next, palpate the chest to locate any areas of tenderness or to assess any lesions or abnormalities.
No.
Now assess respiratory expansion. Place your thumbs along each costal margin with your hands along the lateral rib cage. Raise loose skin folds between your thumbs and ask the patient to take a deep breath. Observe the displacement of your thumbs and feel for the range and symmetry of movement as the patient exhales fully. Next, following this pattern, palpate for tactile fremitus. As the patient repeats 99, use the ball of your hand to compare symmetrical areas.
99.
Because fremitus is difficult to feel through the breast tissue of women, you may need to gently
99.
displace the breast.